Okay, so hi everyone, this is our group presentation on the tympanic membrane. I'm going to be talking about the anatomy, a bit of the histology, and then a bit of the innovation. Then Clarissa's going to go on to more of the clinical aspects. Okay, so just going through the general anatomy, like the ear is a fantastic bit of equipment because it manages to take vibrations from the air outside and then it manages to make it into a signal which the brain can interpret. So starting here, like we've got the auricle or the pinna, and then going medially in we have the external acoustic meatus, and then right here we have the tympanic membrane, which is what we're going to be talking about. So looking at the position of it, it faces anteriorly and slightly inferiorly, and then it's also attached to the temporal bone by a fibrocartilaginous ring. Okay, and then this is a diagrammatic representation of the tympanic membrane, looking at it from an otoscope. So at this point here, we have the umbo, which is where the malleolar handle attaches, and the malleus is the first ossicle of the mid-ear, which is attached to it. And then going superiorly, you can see the rest of the handle until we get to this point here, which is a bulge, and that is the lateral process of the malleus. And then over here we can see that we have an anterior malleolar fold, and then right here we have the posterior malleolar fold. Normally the tympanic membrane is a thick and taut structure due to the arrangement of the fibers. However, right here it's such that it's a bit looser and it's called the pars flaccida, whereas the rest of it is called the pars tensor. Okay, so looking at the histology of it, the tympanic membrane consists of 3 different layers. It's got the outer, the middle, and the inner bit. The outer is more continuous with the skin, and so naturally that is stratified simple squamous epithelium, which is keratinized, which is represented by the C here. And then the middle mucosa is, the inner layer is a mucosal layer, which is lined by simple cuboidal epithelium. And the middle is a fibrous layer which consists of 3 different fibers. So you've got circular, radial, and parabolic. And it's this arrangement that gives the tympanic membrane its thickened, taut structure, or it makes it looser, as I mentioned at the pars flaccida. This bit here represents the ossicle, and as you can see, it is contained within the fibrous layer. Okay. So I'm just going to talk a bit about the innervation now. So on the skin, it is primarily innervated by the auricular temporal nerve, which is a branch of the mandibular nerve, which is a branch of the trigeminal nerve. As well as this, there's also some innervation from the facial nerve and of the vagus nerve, so cranial nerves 5, 7, and 10. Looking at the sensory to the mucous membrane, that's solely done by the glossopharyngeal nerve. Okay, so there's a bigger diagram of the medial look of the tympanic membrane. I'm just going to show you a video now of how the... I'm going to try to.
Did you send me the picture?
The video should be there. I don't.
Did you send me the link to the video?
Yes.
Okay. So then. If you did you ask me to download it for you?
It should be in the email, yeah. Sorry.
Because some of those don't work. Is it that one?
Yeah.
Is that the one?
I think so, yeah. Let's have a look. Is it that one?
Is it this one?
Yeah. Right, okay, so I'll skip a bit. It's about 1 minute. Alright.
Is performed to visualize the external auditory meatus and the tympanic membrane. There are 2 sizes of speculum for the otoscope.
Any idea how to get sound?
Yeah, Paul is not here, unless Paul is here. Paul?
No, he's not.
Yeah.
But you can talk very loud.
Yeah, he's gone. Well, you can talk over it. You can.
It's a bit difficult to do, if I'm honest. Okay, I'll tell you what. Okay, we'll skip this video and we'll just talk about the clinical aspects of it.
You can go to, you want to
We can upload the video on the page afterwards and go through it if that's okay.
We'll see if we can do it.
Okay.
Yeah.
How do I get back to it? Do I just,
No, carry on.
as in like back to the presentation?
Yeah, going to stop sharing.
Yeah.
And then, yeah, share document. Okay.
Right.
Go into the, yeah, that's that one. Okay.
Right, press.
Sorry. Okay, so hey, I'm going to be going through some examples of the sort of conditions that may affect the tympanic membrane. So firstly, I'm going to be talking about tympanosclerosis, which is a condition that is caused by the calcification of tissues in the eardrum and also the middle ear. We can classify tympanosclerosis as either meningiosclerosis, which involves only the tympanic membrane, and intratympanic tympanosclerosis, which involves the middle ear as well, and may even involve the mastoid cavity. Tympanosclerosis is characterized by a chalky white patches on the membrane, and as can be seen in the picture. And tympanosclerosis may be caused by otitis media and middle ear effusion, but it can also be caused by the insertion of a grommet. If the calcification is extensive, tympanosclerosis can even cause conductive hearing loss. Hearing loss is less likely to occur with meningiosclerosis than it is to occur with intratympanic sclerosis. However, it is possible for it to occur if the plaques, the calcium plaques, are very big. The severity of hearing loss largely depends on how much of the middle ear is involved, usually. So tympanic membrane retraction is when either both the pars tensor or the pars flaccida parts of the tympanic membrane are retracted. And this can be caused by a variety of reasons. The first reason being negative middle ear pressure, which is often caused by an inadequate opening of the eustachian tube. It can be caused by there being a weakness in the tympanic membrane, especially after it heals following perforation. And also, if when you have an increased surface area of the tympanic membrane, usually due to an overproliferation of new cells. And this can also cause conductive hearing loss. And finally, we have perforation, which can be caused by traumatic experiences or secondary to infection. Some examples of trauma would be sticking things in your ear, diving up too quickly, or being close to a loud explosion. The symptoms of perforation include sudden pain, hearing loss, whistling, otorrhea, and we can examine this through using an otoscope. Usually perforations heal spontaneously in about 6 to 8 weeks, but if they don't, we can do surgery, such as meningioplasties and tympanoplasties, and we usually only give antibiotics if the mechanism of injury was very dirty. Finally, here's just a picture showing what perforation looks like. Thank you.